Okay, so welcome everybody. My name is Abby Beho. I'm the program director at Lake Health and Wellbeing, and I am going to be your moderator for today. So this webinar is called Tackling Obesity, Lifestyle, Medication, and Policy. And we have two really wonderful speakers, very experienced speakers for you. We're going to have Dr. Pierre, the founder of GoDocta and Urgent Care SKN, and Danielle Walwyn, the Advocacy Officer at the Healthy Caribbean Coalition. So again, welcome to everyone. Feel free to introduce yourselves in the chat and make comments throughout in the chat. So we'll be happy to hear your comments and thoughts about the topic. So I'm just going to quickly just tell you a little bit about us at Lake Health and Wellbeing, and then just go through a few slides just to set the scene for this webinar today. So welcome everyone. Again, to those who've literally just joined, welcome. So just to tell you a little bit about us. So Lake Health and Wellbeing, we are a public health NGO registered in St. Kitts and Nevis, and we aim to improve the health and well-being of our local, regional, and online communities. And we do that through qualitative research to understand the health needs of our community, by advocating for evidence-based health policy, through health education, and also through implementing public health interventions in the community. And this can be pilots, projects, etc., that address particular issues. So this webinar today is a collaboration between ourselves, GoDocta, and the Healthy Caribbean Coalition in recognition of World Obesity Day. And it's also part of our St. Kitts and Nevis NCD Alliance initiative. And it's an educational webinar aimed to sort of build the capacity of all those that are in the room today. So why are we focusing on obesity? So really, obesity is a major public health challenge. It is one of the key drivers of poor health. So we have very high rates of obesity in the region. So over about 50% of people in the Caribbean are living with overweight or obesity. We have high rates of obesity even in our children and young people, and the rates of obesity in young people is on the rise. And roughly 1 in 3 young people are living with overweight or obesity. Obesity is now considered a disease in itself, so it's an issue that we do need to address. But also obesity is a risk factor for many NCDs. So it is linked to heart disease, type 2 diabetes, hypertension, some cancers, mental health, and liver disease. And as we all know, NCDs are a major public health challenge in the Caribbean. We have a huge NCD crisis. 75% of deaths are due to NCDs. 73% of premature deaths are due to NCDs. NCDs are the leading cause of disability. In the Caribbean, we have the highest mortality rates when it comes to NCDs. And of course, NCDs affect our quality of life when you think about the disabilities that they cause, and the way they impact our mental health and physical health. And of course, because of that, it then affects productivity and national development. So it is a major public health crisis for the Caribbean. So what is driving obesity? I'm going to let our speakers go into this in a whole lot more detail, but just in summary, lifestyle factors, genetics, and the environment that we live in, which really promotes an environment of unhealthy lifestyles, really and truly. We have an obesogenic environment that really is causing us to increase weight and to develop obesity. So we have an environment that really doesn't facilitate weight loss or facilitate a healthy lifestyle. We're surrounded by a lot of unhealthy advertising of unhealthy foods, a lot of unhealthy foods. And so we do need to change that. And of course, socioeconomic factors as well is driving obesity. So the purpose of today's webinar is to examine the causes of obesity, to explore the different approaches that we can use to tackle obesity, to look at practical actions and solutions that we can all take, and of course, to encourage dialogue and collaboration across the region when it comes to tackling obesity. So like I mentioned, we have two wonderful speakers for you. So we're going to start off with Dr. Pierre, who's the founder of GoDocta and Urgent Care SKN. And then we'll move on to Danielle Walwyn. Danielle will speak to us about policy. Dr. Pierre will speak to us about lifestyle medication, but also give us a nice introduction into what obesity is and the history of obesity. So after Dr. Pierre's presentation, what we'll do is we'll take 1 or 2 questions just in case people need some clarifications or explanations about anything. And then we'll move into Danielle's presentation. And then after Danielle's presentation, we will open up for a Q&A and discussion where you can voice your opinion, share your thoughts, and ask any questions that you may have. Again, you can put your questions into the chat, and at the appropriate time, we will get to your question. So if you could mute your mics, that would be much appreciated. Thank you so much. So I'm going to just, without further ado, I'm going to hand over to Dr. Pierre to give us his presentation on obesity, lifestyle, medication, and the history into obesity. So over to you, Dr. Pierre. You're on mute, by the way, Dr. Pierre.
Oh, thank you so much, Abby.
You're
Let me
welcome.
just share let me know once you can see my slides.
Yeah, we can see your slides. You're good to go.
Excellent. Again, I want to thank you, Abby, for having me here for this very important conversation. And it came off the heels of a webinar that I did myself, mostly targeting our medical community around obesity, how it was being tackled, some of the conversations around that. So I'm very happy to join yourself and another esteemed guest in Danielle, who's here as well, to discuss something that is a crisis that I don't know that when I listen to different corridors in which it's been spoken about, I suspect that there's concern around amongst the general community, but however, I think where we fall short is on harmonization of some of our strategies. So this is being done in observation of World Obesity Day. And my goal today is to take the doctor hat off a bit and try to explain obesity in a language, in terms of what biology does, where lifestyle comes in, and how medications, which seems to be the new craze, some of the semaglutide and Ozempics that we hear of today, GLP-1s, where they fit in, but also importantly, what can our leaders do, or NGOs as well, in different spheres, different stratas of our society, how we can all come together. The idea of this is eventually to shift the narrative to some extent, where with there's less fragmentation in our approach, and instead we adopt a solutions-based approach supported by evidence, by common sense, and as I said earlier, a harmonization of our strategies. Abby, I just want to reiterate because it's so important. One of the statistics that you shared, which is 1 in 3 of our Caribbean children are either overweight or obese, and that's significant. It's significant because um, some 20 odd years ago, when I was in medical school, some of the diseases that I see today that we considered something of the elderly, or at least individuals who are more middle aged, like type 2 diabetes, we are now seeing the age of onset so much earlier in kids. You mentioned that 75% of the deaths in the Caribbean are attributed to non-communicable diseases. And when we look at the statistics from PAHO and other health authorities, there's a very strong correlation to be made between the rate at which people are dying from NCDs and the rates of obesity, right? So if 1 in every 3 children in the Caribbean is either overweight or obese, then it also makes sense why we also are carrying some of the heaviest burdens in terms of the disease burden for chronic non-communicable diseases, in particular diabetes, where we have the highest rate per capita in the Americas, certainly. Now, these statistics may mean nothing to you, but for those of us who perhaps understand them more at depth, this is a cause for alarm, but alarm alone won't get us there. I suspect that more than anything else, this is a clarion call for a systemic change rather than the individual approaches, rather than the blame, rather than the fat shaming, rather than the reframing, the euphemism that we've attached to big bone and the things that we've used to explain some of the challenges we've had in the Caribbean region. I invite you today, first and foremost, to join me in reframing the narrative. I believe that we would do ourselves very well if we adopted an approach that was a lot more aligned to the WHO's classification of obesity as a relapsing chronic disease, right? Not a choice, not something that somebody who's lazy or a couch potato or chooses to eat, right? No longer can we look at obesity from that perspective, but we have to understand exactly what we're up against, because that's the only way we really begin to make sense of it. And that's the only way we begin to address from a policy standpoint, in a very have a common sense approach that allows us to really tackle this head on. I believe that obesity was born from a perfect storm. And Abby painted 4 main pillars. I've sort of put my obesogenic environment and lifestyle into one and called it environment. So there's that first wave, which is the environment in which we find ourselves today. I'll speak more about that, what has happened in the Caribbean context, but also our biology, which is that this mismatch between what we were designed for and the environment in which we now find ourselves. And then you add a third layer on top of this, which is our policies that just simply haven't evolved nearly enough to address this current crisis. It therefore means that education alone isn't enough because the biology and environment keep pushing in the wrong direction. We can speak as much as we want to, sound bites alone won't do the trick. And it doesn't mean that they're not important, they are, but they must be combined with effective policies. And those policies, I think more than anything else, what you will hear as a recurring theme throughout throughout my few minutes with you is adopting an all of society approach, a coordinated approach. Diets throughout the Caribbean region. I've lived in many of the Caribbean islands, and I can tell you that our diets are very similar. We like and we enjoy more or less the same things. So to adopt any type of policy, to think in any way for a policy for St. Kitts that doesn't apply in Antigua or Anguilla or St. Lucia would be to do a disservice to this effort. If we look back at what has happened in the Caribbean, particularly over from 1950s onwards, what we've done is we've moved from a manufacturing sector where not only was there the manual labor, but we moved into a knowledge work environment where most of our individuals are working sedentary, sitting at a desk for most of the day. And combined with that, we have trade liberalization where we're being forced in many ways to import a number of foods that are processed. They're lower in cost, but they're also higher in the caloric density. So we sacrifice nutrition for calories. Now, in early 2000s, we moved into the fast food sector, the fast food industry, where a Big Mac, a Burger King, or a cheeseburger from McDonald's became a status symbol, right? I mean, you didn't have those things locally, so the country that had them or the person who traveled who had them and said they had a McDonald's, it was a status symbol attached to that. Now we've moved where not only do we have high calorie dense foods that we no longer need to even move a muscle for, we can sit on our couch and order as much of it as we want to. Just this week, Amazon released that, they've moved from 1 day shipping to 1 hour shipping. Imagine being able to get any amount of groceries, any amount of these obesogenic meals, of these high calorie dense meals sitting on your couch. All you've done is you've moved a few fingers. You might get a tendinitis, but you perhaps won't burn a single calorie. So this is the environment in which the Caribbean is right now. This is where we found ourselves, where we've moved from the plant-based meals, where we've moved from an agricultural type of sector to very industrialized in a sense in terms of what our imports are. And I spoke earlier of the mismatch between biology and our current environment. I like to think of it as having a body that was designed for farming, and then one day we open our eyes and we're in the middle of a feast. If I don't know anyone on this call, and I stand to be corrected, but I suspect nobody on this call is familiar with the hunter-gatherer society and that they grew up in that society. But a hunter-gatherer society is known for a couple of things. One, the seasonality of food and a very nomadic lifestyle, which means that you had to walk to eat. Perhaps that's where my grandmother got the saying that a cow that is tied or something to that effect. She said it in French Creole, so I don't clearly recall it, but it's something to the effect that a cow that is tied does not eat or something to that effect. Well, in a hunter-gatherer society, in a very nomadic society, you had to travel. They traveled light. They moved from place to place, chasing after wild game, while the women stayed back to get plants, berries, until the men would return with what they killed, and they would share amongst the society, amongst the entire community, and everyone would eat from that, and then would wait until the next meal of that magnitude appears. Then we moved from there into an agriculture society where we begin to produce. Farms were very close to the home. We no longer had to travel for miles. Food was a lot more what we call food security in the sense that you know where your next meal is going to come from. And as much as this is something that we all aspire to, we understand exactly what the downstream consequences are in terms of the availability of the food that we have, the type of foods that we have, and the frequency with which we consume it. So now we have a very modern environment. So we moved from a hunter-gatherer society where there's intermittent scarcity, high activity, right? To an area where now we can consume ice cream at 2 in the morning, 3 in the morning. We have Netflix subscriptions and Prime subscriptions, and we can binge watch Bridgerton or whatever is popular today, right? Or Virgin River, as someone told me last weekend, while consuming heavy quantities of meals. So what we've done is when we speak of an obesogenic environment, an environment that is lending itself to obesity, it's not just the meals we consume, but it's also part lifestyle as well. In the number of hours that we sleep, the sleep debt that we carry around. I say this and feel hypocritical because I'm perhaps one of the individuals known perhaps to have a very sizable sleep debt, right? But to really understand this, I think as much as I'm trying not to complicate this too much to ensure that everyone leaves here understanding exactly how we've found ourselves where we are and how we tackle it, it would do a disservice to this conversation to not speak of, I call them two brothers or yin and yang if you want to, leptin and ghrelin, the two hormones that are at the base of all of this. And I think we must understand the roles of these two hormones and why exactly we are where we are. There are individuals, I see patients who say to me, Doc, but I'm not eating and I don't understand why I'm not losing any weight. I only have one meal a day and I'm not losing any weight. Well, I like to think of leptin and ghrelin. Leptin as the brake in a car and ghrelin as the gas, right? So leptin says stop eating and ghrelin says to eat. Now, yin and yang cannot or should not operate at the same time. To maintain that balance, maintain equilibrium, there must be that sort of counteraction. One counteracts the other. But what we found in obesity is that this is not the case. In fact, if we think of ghrelin, and because ghrelin is something that that forces you to eat, that is the gas, and we have leptin, which is produced, which is the brake produced by fat cells. I like to think of the fat cells as the brake fluid. So there's brake fluid, but the brake, when applied, isn't working. And if ghrelin is the one who promotes hunger, the one who causes you to eat, and it's the gas, and you're a race car driver, which I think of that's what hunger is, and you're applying that gas, and the brake aren't working, then well, I think we all know what would happen. So in obesity, the brain is no longer responding to the brake, which is leptin. And we need to understand exactly what has happened. Why is it that someone who has massive amount of fat stored from where leptin, the brake, is being produced, still finds it difficult to lose weight, even when they may cut back on the number of calories or the number of times a day that they actually consume a meal. So it is because of that diets as far back as my age would allow me, the Atkins diet, to whichever new craze that exists today, sells you on this water slide model that if you cut back on calories, if you eat as much cabbage soup as possible, or whatever water diet or whatever version of it, you'll lose weight. And it sells because people do lose weight, but it's not a water slide, meaning that when you go down, you don't stay down. I think of it more as a roller coaster because that body that for many years, you've been feeding that body large amounts of calories. Suddenly, you decide that you're cutting back on your calories. Well, the body's it's going to take some convincing for the body to believe that you're not trying to kill it. And so what it does, it begins to conserve energy. It begins to cut back on the amount of that fat that is actually burning to convert into glucose. And in fact, actually, most studies are showing that it takes at least a year before you can really convince the body that this is what I am going to do for the unforeseeable future. But most of us who are trying to get into that carnival costume or are trying to get into that wedding dress or whatever your motivation might be, vacation, summer body, right? Whatever it is, yeah, it works. But then I see you at Christmas time, except if you're in St. Kitts, which is also Carnival. But in most of the rest of the Caribbean, Carnival is in the early part of the year towards summer. But if I see you in December, you've put all that weight back on because you have started consuming the same number of calories and your body has not burnt because you have lost weight, not because you're burning fat necessarily, but because you have stopped consuming calories. So your body's trying to find it, but it's doing so in a very conservative, very sort of slowed approach. So your metabolism slows down. And once you start putting the calories back in rather, the weight starts piling on all over again. So if, and this is why I say, if it takes an entire year before your body is convinced that these new calorie reduction that you've started is the new normal, then we might as well think of it as a lifestyle approach, right? So lifestyle matters, and lifestyle is not just about how much you eat, but how much you burn. So we have to think of the quality of food that we're consuming. If we started by saying that part of our obesogenic environment is just the sheer number of calories that we're consuming. Unfortunately, in the Caribbean, we don't yet have legislation and policy that mandates restaurants to show the number of calories on their menu or on the receipt. But I'll tell you, I'm somebody who I stopped eating cheesecake because if you've ever been to the Cheesecake Factory and you see the number of calories in a slice of cheesecake, it pretty much says that you can't have anything else on the menu. And I can't have that. So when I think of the number of calories that goes into a cheesecake, I say, well, I'll use my calories elsewhere. I can't do that in the Caribbean, so I eat and I consume whatever I consume without knowing fully well how many calories I'm consuming. But if we begin to think of it properly in terms of from a legislative standpoint, but also as well from an individual perspective, the quality of food in terms of the not just the quantity, but the quality of the food that we eat that is poor in nutrition but dense in calories. That's one of the first places that we must make an impact. The second one is movement. Movement. One of the ways that I have my pedometer set to a certain number of steps in a day. I don't always get them in, but one of the ways I got them in is I'd walk around the supermarket. Well, now I can order my groceries, so I don't need to move anymore. And life will always give you a very good reason why you can't get out there and get those steps in, right? So movement is an important thing. Sleep. Most of us don't have a bedtime. Most individuals I hear today, they don't go to bed, they crash, right? So we have poor sleep hygiene, which also adds to increased levels of cortisol, sorry, right? And perhaps cholesterol too, but cortisol certainly. And then there's the stress component of it. Stress in personal life, stress in work life, stress just of today. Look what's happening today. The price of oil, the price of gas, and what's happening in our environment, and Cuba this, and so many reasons to be stressed without proper stress management approaches. This is one of the reasons why we are struggling today. So to really attack obesity in the way that is effective and that is sustainable, we must think of having a sort of an all society approach, but also a very comprehensive and holistic approach to this very important phenomenon. And now I think we've been thrown a lifeline. We've been thrown a lifeline in the form of the GLP-1s. They started off with becoming the celebrity magic drug, spoken about very highly. But GLP-1s are perhaps one of the most important set of medications that have been made in my almost 20 something years of being a physician. GLP-1, glucagon-like peptide, is a natural gut hormone that signals fullness. And these medications, essentially what they do is that they amplify that signal. So individuals who are on these drugs, and I'll show quickly some of the variations that exist, what they eventually feel, essentially feel satisfied a lot quicker. So there's less food. So while they don't burn fat per se, they on their own restrict the number of calories that one takes. So it slows down the movement of food through the GI tract, right? So we feel full quicker and longer. What we find is that appetite decreases, cravings decrease, and in so doing, there's the downstream benefits of decreased cardiometabolic risk. So I'm not going to go into this very complex slide. I have it here in case anybody wants a bit more in-depth explanation of it. But essentially, GLP-1s, I certainly believe that they're not miracle drugs, but in fact, they are perhaps one of the most important set of medications that we have at our disposal today when used properly. And it's not for everyone. It's not a silver bullet. It's not something that you give to every patient, but they are certainly important in the fight against this current crisis that we find ourselves in. I have here some of the different variations. Most of you, I'm sure, are familiar with it. So I won't spend much time going through that, but we can certainly discuss it if needs be. One of the challenges that we have with the use of GLP-1s, and we see patients who spend the money because they're expensive. I think in here in St. Kitts, a month's supply of any of the semaglutides would set you back 1,400 EC dollars. That's some almost 500 US dollars, thereabout, give or take, right? A month. Okay. And people are making the effort, but they're not getting the bang for the buck. You have 25% of that weight loss, right? A lot of it is actually not just um, um, fat being lost, but muscle is an important component of it. So muscle is actually, and this is where it's so important right now. And I say this, we spoke of the whole of society approach in terms of policymakers, but even us as physicians and in healthcare practice, now is the time that we really sort of come around the rest of our colleagues, our dietitians, nutritionists, or individuals in exercise medicine, all of these individuals to really begin to actually create comprehensive plans that really work for our patients, right? Because without proper dieting, without proper weight training, I don't know that we'll make much effort. So what we find is that individuals who are on these medications lose significant amount of muscle mass. At least 20 to 40% of the weight that you lose can be lean mass. And this is why it's so important. Right now, we're seeing protein in everything, protein in bread. McDonald's just launched a protein-rich mac and cheese. Um, with egg whites and whatever else is in there. Okay, because everyone is now hyper focused on proteins, which is not for everyone. Somebody with renal failure, for example, someone who has gouty arthritis, may not be able to actually partake in a protein rich diet, and that is something that needs to be discussed individually with your physician. But it's so important. Why is muscle mass important? Well, I have Danielle here, and I'm sure she's going to speak a lot more about that than I am. But from a medical standpoint, muscle is what actually burns calories, right? It's one of the most energy dense in terms of consuming that the body has. The more muscle mass you have, the more energy required, especially if you're actually using them and you're active. So when you lose muscle mass, essentially what you've done is that you've reduced energy expenditure. And this is why most individuals on those diets, they will lose muscle mass, but not necessarily lose fat mass. And then once they start diets over again, they will begin to regain the weight because it's about function, metabolism, and reducing the regain risk. So that has to be the goal. And to do that, there must be a focus on retaining muscular mass or reducing the loss of muscular mass. Why is the Caribbean uniquely vulnerable? Well, I spoke of the fact that we've moved from manufacturing to being a consumption society where we import and we order everything. Our governments across the region, length and breadth, have spoken about our import bills, right? But we have this rapid diet shifts, heavy import dependence, and we also have the cost barriers. We don't produce anything. We don't import nearly enough in terms of demand what the prices are. So we buy the cheapest goods. And this is why today we stand at 75%, where the rest of the region is 67% in terms of individuals above the age of 15 who may be obese or overweight. In St. Kitts and Nevis is 75%. Yeah. And it's not dissimilar in the rest of the region. So the solution definitely cannot be a piecemeal approach. And it cannot be that we just tell people to try harder. It has to be coordinated. It has to be of society. We have to look at our nutrition and transition imports, marketing to kids, right? Marketing to children, put toys in whatever box or package that we want to put on the menu for them. The cost barriers that exist to healthy options, whether we have to grow more or produce more locally, whether we have to think of increasing safe spaces for walking, for running. And now and because when that happens is we sort of hedge some of the impact of what is happening in the global community. Today, everyone is speaking about the ongoing war in Iran, and Iran is all over is halfway around the world, but the impact is already being felt. When the price of gas goes up and the price of oil goes up, it means that the price of imports go up, and then it means that the food prices, which are already outrageous, are become even higher, right? So this, I want to stick a pin here because I think this is where I'm coming to the meat and potatoes part of this conversation, which is how do we move from this crisis that we find ourselves in to coordinated action? It means that we must first of all build prevention into our plan. I say every day that, most of the Caribbean region, in fact, I haven't worked in a single Caribbean country that is well equipped to tackle all the NCDs that we're faced with. Many of our regions don't have a stroke or cardiac center that they can speak about. And this is what actually we're dying out from, right? Cancers and the likes. So we must build prevention into any of our plans. It means that our primary care system, healthy school food standards and procurement, safe, walkable communities, accessible water, water fountains, and then there must be early identification. If 1 in 3 of our kids are overweight or obese, it means that we must reframe the thinking from what a healthy child looks like in the Caribbean to one that is skinny or maga or whatever number of terms that we use, whatever the adjectives are in your island, right? So we have to do routine checks for our kids, routine BMI and waist. I see kids today who are, it's sad. I've seen kids who have had to have surgery to reinforce the hips because of the size, because of the upper body weight. So there must be screening in primary care. And then we must create referral criteria. This is what I'm proud of at GoDocta, that we've spent so much time building because we believe that this is the only way we actually contribute to this fight in a meaningful way. And then we have to practice evidence-based medicine. Evidence-based. And evidence-based can be harmonized, can be standardized. That if I'm in St. Kitts or Nevis or Antigua or Anguilla, I'm hearing the same thing from the individuals who are caring for my health. Then safe medication governance. So important. It means that we have to protect against the unregulated use of these drugs. They're not cosmetic. Workforce systems and strengthening the workplace. If people are spending so much time in the workplace, this is one of the places where we can make the most impact. This is where we can get individuals together, harmonize groups, harmonize some of our standards. I'm not whatever works. 4 day work week, whatever it is, a gym, a walking group, a way to tackle stress in the work environment. And I'm talking about all sorts of stress from mental health, employee assistance programs. So we need to rethink the way in which we're actually building our society because these are the things that are contributing to us having a society that is now becoming a developmental challenge for us going forward. And then the stigma reduction and public messaging. And thanks to groups like Lake Health and Wellbeing that are doing a fantastic job in terms of ensuring that they spread that message around. I believe that we can achieve this in the next 12 to 24 months. In fact, I believe that this current crisis that is ongoing or impending is perhaps a perfect opportunity for us to come together and harmonize some of our approaches without creating redundancy, without using resources that are scarce to create the same thing over and over again, right? I have put together this plan, and I certainly hope that we get a chance to have another conversation as I wind up this presentation here with you. Everything else I've said here, at the end of the day, all I'm saying is that we are the biggest crisis that we face right now is our healthcare crisis. And our healthcare crisis is so tied to our lifestyle. And our lifestyle is tied to our decisions, not individually only, but also as a society. I believe that in the next three months, we can start looking at health standards at schools, front of package label warnings, marketing protection against to our children, and switch sugary beverage taxes and health reinvestment. We can take some of that money and put it right back into our health sectors. I believe that if we want different outcomes in the Caribbean, we need coordinated action. Healthier school food, clear front of package labeling. At the same time, we must treat people who are already affected with dignity and evidence-based care and lifestyle support, and medications when those are appropriate. I believe this is a critical moment for us to shift from blame, from stigma, to systems and results. I believe we can do it. And I'm not speaking here as Dr. Pierre. I struggle with the same things. I'm speaking here because I believe that the only way we begin to achieve that is if we work together as a society. There are some things that willpower alone is not going to be enough. Somebody just deciding, I don't want to be fat anymore, or I don't want to be obese anymore, or I want to eat better, is not going to make the difference. Not nearly enough at a massive scale that shifts this in any meaningful way. I thank you.
Wonderful, Dr. Pierre. Thank you so much for your presentation. That was really excellent and really got us to think about how we can reframe the whole issue of obesity to one where we shift that narrative of blame and individual blame to one of like systems change and the systems change that we need. So thank you, Dr. Pierre. So does anybody have like maybe one or two quick questions for Dr. Pierre in terms of if you want anything clarified or anything like that before we move on to Danielle, who's going to talk more in depth now about policy. It's a nice segue into Danielle around policy. But does anybody have one or two quick questions for Dr. Pierre before we move to Danielle? Any questions? You can also save them for the end. But just in case you needed anything clarified or any quick questions that you might have had for him. Okay. I mean, there was a comment, Dr. Pierre, in the chat, so you might want to have a quick look. I think that's one of your one from Asante LeBlanc around GLP-1 being a roller coaster as it's abused and misused. So there's a comment in the chat if you want to respond.
Yeah, sure. If it's the Asante that I know, I've known Asante LeBlanc for some times. I can't see that the.
Oh, you can't see it.
What is? No.
So it basically says the GLP-1 ride is also a roller coaster as it is being abused and misused, and once again trying to sell dreams. Mindset change is important. Balance is key.
Yeah, absolutely, and that's why I said that that one of the pillars has to be policies against medications. It's unfortunate that we don't have a strong enough pharmacy act. People bring in any medication, we don't know what the sources are, and also as well that people see that as a way to make a quick buck. But I tell individuals all the time, if you keep people around and keep them healthy, you'll have customers for life. But if I can sell you these medications, $1,400 a pop, and you haven't really lost weight, there's been no real impact to your health, and perhaps you are not even suited to these medications. We continue to adopt things like the new fad, the very same way that everyone is doing vitamin IV therapy. Everyone is, it's crazy how we jump, and it doesn't mean that those things may not have their uses, but the way in which we're selling them to individuals. If we have somebody who's willing to roll up their sleeves and have you put something in their vein, do it sensibly. Let it be evidence-based. And because we may not be able to put in place or depend on the willpower of one person over the other, this is precisely why policies come into play. Policies are meant to protect society, especially the most vulnerable amongst us. People want help. They clearly do want the help. That's why they're going out there to get it. Well, if they've bought into that trust and they've established that trust with you, I've always said that, this is the greatest privilege of my life, to be a physician, because nobody establishes trust as quickly with another human being as a doctor. I've heard things that people's spouses and their priest would not have heard, right? So if someone has trusted you in that way, why abuse it? Why not use it in a way that truly helps that person to achieve their that end goal? So Asante, I'm with you on that. I certainly think that you're absolutely correct. But I'm hoping that we can come together as a society and lobby for the policies that would help protect us against those.
Wonderful. Thank you so much, Dr. Pierre. Appreciate you. Thank you very much. And so now we're going to move on to Danielle Walwyn. Danielle is the Advocacy Officer at the Healthy Caribbean Coalition, and Danielle is going to pick up where Dr. Pierre left off and talk to us about policies in more detail. So over to you, Danielle.
Great. Thank you, Abby, and good evening, everyone. It's a pleasure to be here and really appreciate Lake Health and Wellbeing extending the invitation to myself and broadly to HCC to participate. And thank you, Dr. Al, for a really interesting conversation and for really emphasizing the need of this whole of society approach. And so my aim today is really to sell you, if you're not already sold, on the power of policy as one of the tools to address obesity. And so we are going to be journeying together today. We're going to be talking about our reality, or really just re-emphasizing what Abby and Dr. Pierre would have mentioned about the current environment that we live in, the fact that our environment, unfortunately, is an obesogenic one, and it really is shaping what we're seeing in terms of obesity and broadly non-communicable diseases. And I'm hoping that we can humanize this whole idea of obesity. We're going to meet Eden, and I'm going to invite you to think about the Edens in your life when we do get there. The other part of this presentation will focus on policies and policies that we know are evidence-based, so those that are recommended by the WHO and our regional partners. And I'll say in advance that it's not an exhaustive list, or I won't be able to present an exhaustive list, but I will share the ones where we have seen some progress across the region. And then lastly, inviting everyone to just reflect based on the information that Dr. Al has shared and that I will share as well. And the last thing I'll say before I dive in is that I am going to be using color today intentionally. So whenever you see the background of this screen turn black, this is my invitation to you to really zone in on the content of the screen, inviting you to reflect and think about the information that's on the screen. Okay, and really do want to hear your thoughts and feedback throughout the presentation. So we're starting off with our reality, thinking about us, as I'm assuming all of us are adults, the kind of world that we live in, the choices that we make, the environments that we live in that inform the choices that we make. And again, Abby and Dr. Al really presented an overview of our current reality. We have non-communicable diseases across the Caribbean region that are at exorbitant rates, relatedly obesity rates. And what's particularly concerning is also our childhood obesity rate. So we heard the stat, I think we know the stat, 1 in 3 children are living with overweight and obesity. And I think what's important for us to remember is that these habits that children are forming in childhood are likely to track into adulthood. So if we think about that stat, we have to think about what that means in 10 or 15 years. And as Dr. Al said, he's seeing the implications of obesity, not even 10 years from now, what children and young people are facing today. And one of the driving factors with this exorbitant rate in NCDs and obesity has been an unhealthy diet and that nutrition transition that Dr. Al shared. And one of the main culprits here is ultra processed products. So we've seen a high importation of these products. These are foods that you cannot make at home. They have all these additives. They are high in the critical nutrients, salt, sugar, and fat, and very low in nutritional value. You can kind of get a sense based on one of HCC's campaign images there, but the kind of foods that I'm talking about. And the reality is that these foods are very affordable. They're very affordable. They're heavily marketed. They're everywhere. And so this is one element of our food environment that really is contributing to what we're seeing today. Our physical activity environment. Dr. Al spoke about it already, but I invite you, black screen, to think about your physical activity environment, your opportunities that you have or might not have individually, and how that relates to, again, the environment around you. Is physical activity being promoted at work? Do you have access to affordable physical activity opportunities and spaces to be active? All of these things, again, contribute to the physical activity environment and why we've seen a significant decline in physical activity. So what do we need? Obviously, we need to do something. We heard from Dr. Al about kind of the spectrum of activities and initiatives that we need to take. But one in particular, especially when we're talking about impact for all populations, is policy. It really does try and shape environments where the healthier choice is the easier choice. Think about policies that we're very familiar with: seatbelts, smoke-free environments, alcohol regulations. All of these are really trying to provide a protective blanket, and especially when we're talking about health policy, really trying to ultimately protect our health. And so there has been evidence about the kind of policies that we do need to implement to address obesity. This has been recommended by the World Health Organization. And as I mentioned earlier, it's also echoed by our regional partners like CARPHA, Caribbean Public Health Agency. And so ultimately, what we really want to do with these policies is, again, reduce the demand for the unhealthy things, so those ultra-processed products, but also at the same time, do what we can to make the healthier options, whether we're talking about food or physical activity or mental health support, more accessible. So you can get a feel of the kinds of policies that are being recommended. As I said, I don't have the time to go through all of them, but I will be able to touch on those that do have a green asterisk by them. And before I delve into the specific policies, I did tell you we were going to meet Eden, and here she is. So Eden is a 6-year-old girl. She attends a school that doesn't prioritize healthy options. Instead, ultra-processed products are widely available and heavily marketed. She only has PE class once a week, and physical activity is not recommended or is not offered outside of PE class in her school. She lives in a community with poor lighting, which makes walking or playing outside difficult. If you know an Eden, or if you have experienced some of these realities, I would love to hear your thoughts in the chat. And I want you to also keep your Eden in mind as we're navigating through this presentation. So we've now kind of spoken about the environment, right? And that was echoed from before. And so now we're going to talk about the actual policies that, again, are evidence-based and have been recommended to address our obesogenic environment. And so one of the primary policies is food labeling. Why do we need food labeling? Related to, again, the products that we're seeing in our environments. A fact is that there is an excessive consumption of products that are high in critical nutrients, sugar, salt, and fat. It's a public health problem. They're in our food, especially these ultra-processed products that we are seeing everywhere. So really, what do we need to do? We really do need to help consumers, because oftentimes you don't even know whether these products have in high levels of these critical nutrients, right? So we need to help consumers identify which products contain excessive amounts of those critical nutrients. And let's be honest, people purchase things in seconds. You pick things up, you're not looking at the back of the pack or in the nutrition facts panel. You are picking things up quickly. I think we've all been there. People have a right to know what's in their food. And again, the back of pack, which is on most food, can be very difficult to understand. And knowing what's in our food is especially important for people who have diet-related conditions, right? And so we really do need a solution. We really do need an option to help people quickly, easily, and correctly identify what's in their food. And there are hundreds of different labeling systems. There are many different front of package labeling systems, but the most effective labeling system to again help people quickly, easily, and correctly identify what's in their food is octagonal front of package warning labeling, which is guided by the PAHU nutrient profile model. And essentially this model helps to identify whether a product is high in a particular critical nutrient. So like the soda on the screen, a packaged product, so a soda or a snack package would have these octagonal labels on the front of them in an ideal world. Black screen, inviting you to zone in with me. So if we think about what if these labels were to be implemented on our packaged foods, what impact would that have on Eden, my Eden, your Eden? And a really cool thing is that this particular labeling package has been implemented in countries in Latin America, including Chile. And it was found that children understand the packaging, the labeling. So that's a win for Eden. She's actually able as a young child to understand what the labeling means. The really other cool thing is that the front of package warning labeling works hand in hand with other policies that we're trying to promote. So imagine you have this labeling system and you're able to easily identify which product is high in these critical nutrients. So in that case, you're able to identify which food should be allowed in Eden's school, because the ones that are high, obviously you don't want them in her school. Similarly, it's easier to identify which food should be taxed, because that's already been determined which foods are high in those critical nutrients. And lastly, you're also able to identify which food should be marketed or not to Eden, right? So this is a perfect example of how all of these policies can work really well together. So where are we at with front of package warning labeling in the region? So some of you may be familiar that we were actually considering implementing this labeling system across CARICOM. The process started in 2017. It's been a long process. There were 2 votes by member states to determine whether we wanted to move forward with front of package warning labeling, guided by the PAHO nutrient profile model. Unfortunately, we weren't able to move forward with the labeling system because we did not get enough votes. And our last update is that in 2025, the Caribbean CROSCU, the CARICOM Regional Organization for Standards and Quality, so our standards body, proposed an embedded QR code on packaged foods. So we're interested to see what the next steps are there. Of course, we know what the most effective option is for us. But and it'd be interesting to hear Asante's thoughts on this. We had the Minister of Trinidad and Tobago actually note that he and his ministry is exploring warning labels on processed foods, so coming soon. So that is an interesting and welcomed initiative. So we'll see what happens there. So that's labeling. So that's one of the proposed strategies, again, to help address obesity and broadly other NCDs. And now we're moving on to the school food environment, which is another key area, especially as remember, we know so many children spend most of their day in school. The behaviors that are developed in childhood are likely to track into adulthood. So it really is the perfect opportunity for us to intervene. And I'm really pleased to say, and you'll see in another slide, that this is one area that our ministries across the region are exploring, which is very exciting. So we do need a whole of school approach also to addressing obesity. And when we're talking about food in particular, we know, and Dr. Al mentioned it, the schools have, those that especially don't have any regulations, there are high levels of ultra-processed products in and also around schools. We also have instances where we're seeing unhealthy food brands sponsoring school events. So it really, again, needs to be a place where we're prioritizing healthy options. So these recommendations from the WHO, they're recommending, and I'll say that the WHO just launched a new resource specifically for supporting healthier food environments. I'm happy to pop it in the chat so that you have a copy, but these are derived from there. So the WHO recommends direct food provision to students in schools. So meal programs, fruits and vegetable distribution, that makes sense. And they're also recommending that that sort of distribution is guided by nutrition standards. Also makes sense to ensure that we have quality food that's being offered to our students. And we're all in luck. CARFA and the Pan American Health Organization just launched recommendations for nutrition standards for Caribbean schools. So we have a local, regional grown resource to guide us there. Thirdly, nudging interventions. This is one that I found particularly interesting. So doing little things to help promote healthy food behavior in the school environment. So for example, if we're thinking about a canteen, where are we placing the healthier options? Where are we placing the unhealthier options? Similar to thinking about a supermarket and what we see at the checkout. Are those healthy options or unhealthy options? So I found that that was an interesting initiative. Fourthly, marketing restrictions. We've spoken about those already. We know how critical they are because what is marketed influences our behaviors and our consumption. Our influences our preferences and consumption. So imagine if you're being bombarded by unhealthy food marketing every single day, what that might lead to. And fifthly, pricing policies to promote foods and contribute to a healthy diet in schools. And we'll touch a bit more about that, particularly when we speak about taxes and fiscal policies. So again, inviting you to zone in with me, checking in on Eden, thinking about your Eden. School nutrition policies, they're very powerful. And if implemented, they really could normalize healthy foods. Because right now it feels as if unhealthy foods is what's normal. So imagine having policies that restrict the sale and marketing of these ultra-processed products, the impact that that would have. Reduce exposure to unhealthy products in schools. And supportive environments to learning. And I feel like this particular point we often overlook, how critical it is to have healthy foods in place to support better learning and better learners. I know as advocates, that's one of the key things that we've been considering in our advocacy messaging. So as I mentioned, there has been really great progress with school food environments and healthy school nutrition policies across the region. So Jamaica actually approved their school nutrition policy in 2005, and this was a collab effort between the Ministry of Education and Youth and the Ministry of Wellness. I will say Ministry of Health and Wellness, apologies, and I will say that they would have announced last week that they've been doing some really great collaborations with different ministries to implement the school nutrition policy. For example, working hand in hand with the Ministry of Agriculture to source healthy foods, to support, again, thinking about one of those recommendations from the WHO, the healthier options in school food environments. Trinidad and Tobago was the newest one out on the block. They, in January 2026, announced the desire to strengthen nutrition guidelines for food and beverages sold and served in schools. So this is building on a previous regulation that they would have had where they were focusing on the sale and serving of sugar sweetened beverages, and now they're expanding that to also include packaged snacks. In Belize, we have the school nutrition policy, which was approved in 2005. Again, a really comprehensive effort, and they're exploring, going to explore marketing and also exploring conflicts of interest and how to manage that within the school food environment. And then lastly, Barbados, who I think those of us who have been following what's happening in schools look up to. Barbados was the first out of the gates with launching the policy in 2022, 2023 in a phased approach. And we heard recently that they're doing some monitoring and evaluation of how many schools, for example, are compliant. Just a reminder of how important it is to have the M&E integrated, which sometimes we often forget. But this was also a great collaboration between the Ministry of Health and the Ministry of Education. Fiscal policies. So again, so far we've talked about the food labeling, we've spoken about the school environment, and now we're going to talk about the money. And when we're talking about fiscal policies, we're really thinking about strategies to reduce the affordability of unhealthy food. So this often comes in the form of taxes or strategies to increase the affordability of healthy foods. And this often comes in the form of subsidies. And so why do we even want to explore this particular policy? How does it impact the obesogenic environment that we've been talking about? And I want to draw your attention to the image on the left. And this is showing the affordability and the increased affordability of sugar sweetened beverages. This is our reality. The unhealthy or the products that are high in the sugar, fat, salt continue to be very affordable. And taking your eyes to the right hand of the screen, this was from a recent FAO report on food security and nutrition in the region. And the Caribbean has one of the highest rates of a healthy diet, most expensive healthy diets. And so this is why we really do need to intervene in this way with fiscal policies. So how are we doing across the region? Fresh off, as of 2026, Jamaica has announced a special consumption tax where they're going to be applying a tax to a series of items, including sweetened beverages. And I think important to note here is that they're considering beverages that have artificial sweeteners in them, and that might not be the case sometimes in other countries. Barbados had a 10% tax that was implemented in 2015, and this was increased to 20% in 2022. And then lastly, I want to draw your attention to Antigua and Barbuda. So the policy was approved in 2023. And really interestingly, the policy includes restrictions on the sale and marketing of sugar-sweetened beverages in and around schools. So this is a really interesting addition, just going back to this whole idea of the need for a comprehensive approach, especially when we're talking about policies. And in the proposal for the levy, they're also considering earmarking, and this was on Dr. Al's slide about kind of, what we need to be doing next, earmarking funds towards health promoting efforts. And we know that that's kind of the way that we want to go. So we're interested to see how things move forward with this levy in Antigua and Barbuda. Now, so that was the taxes point. And now, again, when we're thinking about fiscal policies, we want to decrease the affordability, we want to increase affordability of maybe the healthier options. So subsidies have been considered across the region. And I just want to draw your attention to two examples. The Bahamas, so as of April 1st, the government is going to reduce the value-added tax on unprepared food items, which include fresh fruits and vegetables. So there's been a slow decrease on the percentage, and they're moving to a zero-rated VAT. In Barbados, this was last year, the government removed VAT and import duties again from specific fruits and vegetables. Dr. Al is giving me a heart. So there is some progress. It'll be interesting to see us continuing to monitor these particular initiatives, but we are seeing some things again across CARICOM. Zone in again with me. Eat and check in. So we can see that the implementation of these fiscal measures could reduce exposure to sugary drinks, because essentially what we want to see happen with sugar sweetened beverage taxes or sweetened beverage taxes is there is reformulation where we have a at least from the manufacturers, healthier options being offered, and not healthier options with artificial sweeteners, healthier options, and also just a plain reduction of these sweetened beverages. And so you can see how that could impact the environment that Eden's in. Implementation could also increase the availability and affordability of healthier options. Again, thinking about what we're seeing in other countries with the subsidies, or what we might see in countries that might earmark tax money, tax funds towards healthier options. And on that third point, if the tax funds are earmarked, we can support health promoting activities as is being explored in Antigua and Barbuda. All right, the physical activity environment. So we spoke about some of the food policies, and now I am inviting you to also remember or think about, reflect on your current physical activity environment and what that looks like. So the World Health Organization is recommending a series, again, very much aligned with this whole of society approach of what we need to do to address our physical activity environment. And I'll start on the left-hand side, active environments. So it's 4 pillars. The first is active environments, and I think that one's pretty self-explanatory. We really do want to create actual environments whereby we can be more active safely. It also includes, which is often overlooked, how we manage or support active transportation. So what do we have in place to ensure that persons can get from point A to point B, traffic calming measures, etc. Active societies, this is all about normalizing physical activity, referencing the benefits and co-benefits of physical activity. So an active society's activity might be a campaign and we've seen those with our various MOVE efforts across the region where we're promoting physical activity. The active people is all about the opportunities and what's happening, for example, in workplaces versus school food environments or school environments. What are we doing in healthcare centers to promote and encourage movement and physical activity? And then the active systems is kind of the thing that brings it all together. What do we have at a systems level to support all these other interventions? So, for example, what research do we have, particularly for our unique populations, and especially if we think about vulnerable populations, what do we have in place to guide physical activity interventions for those persons? What partnerships do we have in place? What policies do we have in place? So it really is the thing that ties it all together. So again, if we're thinking about Eden, what initiatives do we have to support her environment? And if you might remember from her story, she lives in an environment where there's very poor lighting. So physical activity after school at home is unlikely unless she's doing it in her home. So for active environments, we're ensuring that there's traffic calming measures, so she could perhaps walk outside, that there's lighting, that there's maybe green spaces in and around her school. For active societies, as I mentioned, we might want to consider a campaign that's promoting physical activity among children and among families. So we're kind of, again, normalizing what this could look like. For active people, thinking about what sort of physical education program are we ensuring that Eden has access to in school? Is it just that one-off PE session, or are we ensuring that there are other ways that she can be active? And then, as I had mentioned before, really thinking about under active systems, how we're going to sustain a physical activity environment, whether that's research, whether that's funding, or otherwise. So how are we doing across the region? And really, I spoke about all of these things. Eden, it's also thinking about how we create a physical activity culture, again, where she can develop healthy physical activity habits that can then track into adulthood. And how are we doing across the region? I think everyone is familiar with the Caribbean moves, Jamaica moves. I hope I haven't missed any, and it would be interesting to hear your reflections on maybe your local moves and an initiative that has been launched by them. But we have made some progress. But unfortunately, we have had some, although there's been some progress, I'm looking at the time. I know I have a couple minutes left, but although there has been some progress with policy implementation, we really do still need to think about, and Dr. Al had mentioned it in his presentation, why we're not making progress in other spaces. And this is the PAHO NCD Progress Monitor, which, as you can see, on the left, we have our countries in CARICOM, but then we can see the various health promoting initiatives and policies listed, and we see a lot of red. So although we have progress, there is still inertia that we have to address. And what can we do about that? Or when we think about the why, and it'd be interesting to hear your thoughts too. Political will comes to mind, really wanting to drive these policies forward. And we have seen some fantastic leadership where, again, we have seen the policy success. And so we really do want to see that replicated. And then the other part of this is, and these are not the only two, not to be exhaustive, but the other part of it is the commercial determinants of health and thinking about how industry might be playing a role in influencing our policy progress, or might be diluting policies or halting policies altogether. And so it's very important that we ensure that we have the safeguards in place to protect our policy making spaces. So finally, final thoughts is, when we're thinking about where we want to be in the next 5 years, I know Dr. Al mentioned 6 to 12 months, but thinking about the next 5 years, shifting from policy development, which a lot of countries are still in that development phase, we really do want to see a movement towards implementation and sustained monitoring. There also needs to be efforts focused on strengthening existing policies like what we've seen in Trinidad and Tobago. And then in order for our policies to be truly reflective of our people and our needs, there needs to be meaningful engagement, institutionalized meaningful engagement of our civil societies, youth, other vulnerable populations in the policymaking process. We need to ensure that there is, again, reinforcing conflicts of interest safeguards to protect the policymaking spaces and ensure that it's always people over profit, and then always be guided by evidence. So just finally, inviting you to think about all that we've spoken about today with Eden and consider what we need to do to ensure that her future looks a little different. And so hopefully we've covered the reality piece. We've covered what our environment looks like, what a piece of the puzzle is, which is policy, and what that has the potential to do and has already done in some cases. And also just, again, thinking about our reflections about where we want to be and emphasizing that policy is really critical to help create that environment where we want to see the healthier choice be the easier choice. Thank you so much. Sorry to have gone over by a few.
That's quite all right. Thank you so much, Danielle. Great presentation and a really nice, comprehensive, and informative look at all the policies on all, but the main policies that we need to think about when we're trying to tackle obesity. So thank you so much for that presentation. So does anybody have any questions? So we're now going to move on to the Q&A and discussion portion. So I might ask Dr. Pierre to put back on his lovely video. And then does anybody have any questions, comments, thoughts, anything about what you heard today? And I have to apologize. I think there was a little bit of confusion around the time. A few people thought that the session started at 7, but it actually started at 6. So for those that thought it started at 7, we'll make sure that you get the recording so that you can catch Dr. Pierre's presentation because it was really good. And also the beginning of Danielle's presentation. So any questions for Dr. Pierre or Danielle, or just any thoughts on what has been discussed today? Any thoughts, anything that anybody would like to share before we close out? We've got 10 minutes for questions and discussion. Any thoughts? Okay, we have Miss Williams, Shamika Williams. Over to you.
Hi, good night. Can you
Good
hear
night.
me?
Yes, we can hear you. A bit muffled, but we can hear you.
Okay. Hi. Sorry, my 1 second.
Okay, no problem.
Okay, so I am Shamika Williams. I'm a pharmacist in Grenada and also a part of Healthy Caribbean Coalition Youth.
Okay.
So I do want to agree with Dr. Al's sentiment about there being lack of policy as it regards to pharmacy in the region. There isn't enough pharmacy inspectors, I should say, who would go around and ensure that the medications are of standard and even on the ports. That's something that needs to be worked on. So that's my first comment. And I guess my question slash comment, being a pharmacist, what we get a lot is persons, parents of young children, hey, my child's not eating. Um, I need something to open the appetite. But when you question the parent, oh, well, they're on the device for hours upon hours. Um, yeah, and perhaps they're not doing the food, but they'll do snacks. They're eating snacks, they're not eating the food. So how can we break away from that mentality or address that challenge of um, thinking, oh, just give something to open appetite, that kind of stuff.
Yeah, Dr. Pierre, you want to take that first?
I thought you were going to go to Danielle. No, this is such an important question, and it's not only important from the standpoint of because it's so widespread and so commonplace in the Caribbean, but also because it's there to me. It's something I struggle with in my family. I tell my siblings all the time in terms of the sort of pressure they put on kids and just the conversation around how we eat. I want to just dial back to my presentation to the start of it that spoke about our bodies, the one we still possess today, being designed for famine. We really the idea of a meal every 8 hours is commercialization, right? It's really about the fact that we live in an environment where we consume large amounts of food and more often than we typically would if we were in an environment that didn't allow for it. So when we speak of an obesogenic environment, we're speaking about not only the quality of the food, but the quantity in terms of the quantity of food that we consume in any given moment, and the number of times in the day that having a snack has become fashionable to have something to snack on. Have a bag of Cheetos next to your bed, so you don't have to walk to go get it. You can just like grab it and just start snacking on it. So when we speak of an all of society approach, this is precisely why this is so important, because this is not something that I, as a physician, would typically be able to tackle. And this is why I tap into my dietitians, even mental and behavioral wellness individuals, experts, to really begin reframing the dinner table conversation around
Mm.
how we eat, what the practices really are. And this is because if we're waiting downstream, if I'm only waiting when that patient or that child is already showing some type of metabolic disorder to get into my office, I'm already too late. I'm already too late, one, because there's a disease process that's already set in. And I'm already too late because there's a habit. Let's not underestimate the just how addictive sugar is, right? There's tons of research that has shown that sugar is even more addictive than cocaine, right? Where mice were being, given cocaine, and then once they tasted sugar and got used to it, they left cocaine for sugar. So there's the addictive component of this where it's not about but unfortunately, we still tie food consumption to standard of living. If I have a fridge that's packed, it means I'm doing well. If I go to the supermarket and my shopping cart is not filled to you know, I'm not doing well. Poverty for us is how much food you have in your house versus the one who doesn't. If you come to my fridge and you see a jar of olives, you'll see I'm doing pretty bad, right? So we must advocate for the children. The children get up and they want to snack on something. So there's an obsession. I think the relationship we have with food in the Caribbean needs to change, but that's not going to change overnight. Because for that to change, first of all, there has to be redundancy in our messaging. It means that as I go around, I'm hearing the same message spoken all the time. I am a lone wolf in my family, speaking about the fact that why are you forcing the child to consume food? Why is a child even up at 11 o'clock in the night having a meal? First of all, there's a sleep deprivation component. And two, that child is not consuming anything that is healthy at that point. Because at that point, it's just cravings being satisfied. This isn't hunger speaking. The fact that a child can continue to be on a device and not feel when somebody's hungry, believe me, they eat. So if a child isn't eating and the child does not have any poor nutritional status, the question is, what are the standards? What yardstick are you measuring how much or how often that child is eating by? So it's a conversation that, and please do not do like a lot of pharmacies who give them periactin and all the other things that they give kids. You have kids who are drowsy, but their appetite is because periactin is an antihistamine, a sedating antihistamine, right? So it makes you drowsy. But there are a number of parents who give their kids periactin so they can eat because he's not eating. But then he's not eating based on what? And then even when the child starts eating, gosh, what you feed the child eating because you go to Burger King and you go to pizza and you go to this one and so on. And I'm not knocking any of these food places. I'm not. I'm only saying that we need to reframe the conversation. It's going to take a massive cultural shift, but it has to be that the pharmacist who sees this and says, listen, that's not, not no, because that person is just simply going to go somewhere else and get it. And there's always a pharmacist who's willing. It's about how we all have language that we can use in moments like this that actually sends that person, not kick the can down the road, but certainly sends that individual to the next person. This is why I love GoDocta. This is why I've invested all my life, the last few years of my life, into building this because I want to build a central space where a patient can walk through that one door and find all the help they need in that single location. Because I cannot trust that person, and not because they don't want to, but I am up against such a battle that when I say to you, go see nutritionist so and so and make an appointment, and you don't know, I can't tell you the address, I can't make the appointment for you, I can't tell you when, you're not going because for you it's not a problem. So I don't know if I answered your question because I don't really have an answer, but I kind of have an answer, but I realize it's what Daniel and everyone is saying. Like it has to be an all of society approach, redundancy in messaging, front of label of thing packaging. When I saw this octagon thing, I was like, I started pulling up items seeing that this was already in existence. I'm like, I haven't seen those octagons anywhere, but it makes perfect sense. It makes perfect sense, right? All the if you go to look at what's next to the checkout counter and take your little boy or girl and so on there and see what happens. That's where all the candy, all the unhealthy things, they're right there. And I keep asking I said, why don't you put like some healthy stuff, like some nuts and so on right there? Let this be the compulsive sort of bias that people have. No, but that's where all the unhealthy thing is. While the child is at the counter pulling, mommy, can I have? So I hear you, I hear your plight. I try to do my bit, but I know that once somebody steps out of my office, it's why I take an hour with every patient of mine. It's a known fact. And an hour isn't even enough because I have so much work to do. I try to fill in so many gaps. But I think that if we all begin to speak the language, and I hope Danielle will and the folks, not no pressure at all, but in the HCC would give us language that we can use and that we all speak in the same thing. I think if all of us here on this call today, there 30 something of us, start speaking the same language in different parts, I believe at some point it begins to shift things. That's my thoughts around that. Thank you for
Thank
your
you.
question.
Thank you, Dr. Pierre. Over to you, Danielle. Danielle, you wanted to add?
Thanks, Abby. Just quickly, and thanks, Shamika, for the reflection, and a big shout out to Healthy Caribbean Youth members who are on the call. Just to add, Abby, to Dr. Pierre's comment about this, having the right people in the room, I'm just thinking about from the policy implementation standpoint, the case study that I'm thinking of is Jamaica and how the Heart Foundation of Jamaica has been really, and not just the Heart Foundation, our civil society partners there have been really pushing for nutritionists and dietitians to be a part of the school nutrition policy process there and the implementation. It makes me think, Dr. Al, to your point of also mental health professionals just having the right people in the room to make the link about the multiple benefits that can be achieved through having a comprehensive school nutrition policy. So just emphasizing your comment on at that, I'm sure at that individual level, physician level, but also that same recommendation can be applied to the policy level, development and implementation too.
Wonderful. Thank you both so much. So any other questions or comments? Any other questions or comments? All righty. It looks like no more questions or comments. So if there are no more questions or comments, or if you wake up at the middle of the night and you have a question or comment, you can email it. And I will make sure that it either goes to Danielle or Dr. Pierre, and then you can get an answer. So I guess then it's just left to say thank you. So I'd really just like to say a big thank you to Dr. Pierre for his presentation. So Dr. Pierre spoke first, and we appreciate, your really comprehensive look at how we can reframe obesity and changing it from something where we're thinking about individual blame to thinking about systems change. So we really appreciate that. We appreciate the fact that you gave us a nice sort of introduction into how we started off historically living in a world of scarcity, and now we're sort of in this world of overabundance and overconsuming, and how we really need systems change to address that. So we thank you so much for that. And then thank you so much, Danielle, for your presentation on really walking us through very nicely with a nice visual representation through Eden of the policies that we need to address all of these issues. And really what we're thinking through is how can we advocate really effectively to get those policies not just written, because we have lots of policies written and on tables, but how can we make sure that those policies are implemented? So thank you so much, Danielle. Also, thank you generally to the Healthy Caribbean Coalition as well for all the work that you do across the region, which has really just been, so instrumental to all of us NGOs working locally, in terms of advocating, all the support that you provide and all the information that you provide. So thank you so much. And of course, thank you, GoDocta. Thank you, because this webinar was inspired by GoDocta and Dr. Pierre's presentation that he gave to doctors in December around medication and obesity and lifestyle. So thank you so much, Dr. Pierre, for agreeing to sort of adapt the presentation to suit the audience. Thank you everyone for joining today. We really appreciate it. We hope you found the session today to be useful. We hope you can use what you learned today in your advocacy as well. And so sorry to anybody who joined thinking that the session started at 7. We'll make sure that you get the recording. I'm not sure what happened there. I don't know if it's something to do with the time change with Eastern Time and AST. Maybe so apologies for that. So we'll make sure that you get the recording so that you can see Dr. Pierre's presentation. And so I think that's it. So thank you everybody for joining. And we will make sure that everyone gets the recording and links to any resources that you might find useful. So thank you so much.